Yes, sir. Please.
Respected judges and my seniors, at the outset, I would like to express my sincere thanks for having been given this opportunity to present my case in this prestigious academic session. Before I move on to my case, which is titled Unusual Response to a Magnet, for novices in the audience like myself, I would like to first discuss what actually a magnet does to a pacemaker. Most pacemakers and ICDs have built-in reed switches, which are programmed to switch on or off in response to external magnet application. Several newer pacemakers have alternative technologies, but that is beyond the scope of this discussion. A reed switch consists of two metallic strips made of magnetic material housed inside a glass capsule. They are kept separated by their stiffness and a cantilever attached to the end of the capsule, and on the application of an external magnetic field, which leads to the strips being coming in contact with each other and leading to a closed reed configuration. This leads to a change in voltage, which is sensed by the sensing amplifier and which triggers the pulse generator to perform some programmed functions. These programmed functions can be asynchronous pacing in pacemakers or switching off of anti-tachycardia therapies in ICDs. So, in summary, a magnet causes switching to an asynchronous mode, and we can find out what is the we can predict what is the manufacturer, device model, and status of the battery, because the magnet induces a fixed magnet rate at a programmed delay depending upon the battery status and the manufacturer. So a DDD becomes DOO, a VVI becomes VOO, and AI becomes AOO. In short, it makes the pacemaker blind. The rate responsive feature is also switched off on response to magnet application. So there are several utilities. Not going into the detail, we can know about the battery status. Because the pacemakers are blinded by the magnet application, they turn to asynchronous mode. This can be made use of in conditions where there is a chance of an external magnetic interference or interference by cautery during a surgery. It can also be used to terminate a pacemaker-mediated tachycardia. There are several manufacturers which provide a threshold margin test through which we can find out the capture safety margins. It can also be programmed to trigger EGM storage without effect of pacing. Now, with this background knowledge, I go to the case in question, which is of a 48-year-old male who had coronary artery bypass grafting and a mitral valve replacement with submitral aneurysm repair in 2016. Did well for 1 year, then developed infective endocarditis of the aortic valve, subsequently underwent an ascending aortic repair and an aortic valve replacement with tricuspid valve annuloplasty. However, in the immediate post-op period, he developed a complete heart block, for which a Medtronic dual-chamber permanent pacemaker with an RV apical lead was implanted. Since then, he has been asymptomatic and came just a month back for a routine follow-up in our device clinic. Now, as a protocol in our institute, for every patient who comes to a device follow-up, we do a 12-lead ECG without and with magnet. So this was the ECG without the magnet. 12-lead ECG, which is showing an RV apical paced morphology as exemplified by QS in 2-3 AVF and an LBBB configuration in lead V1, and along with an A-paced V-paced rhythm, which at a lower rate of 70 beats per minute. What is unusual here is there are intermittent VPCs which come, which appear to be coming after every fourth beat, so giving rise to an impression of a pentagemini. But because the patient has an underlying structural heart disease, it was not surprising to see this. However, on magnet application, something very unusual and interesting came up. When we applied the magnet, because it's a Medtronic pacemaker, the first 3 impulses are being provided at 100 beats per minute. That is for a threshold margin test. These 3 impulses are provided at the programmed amplitude, and the third one at a 20% of the programmed output to check the capture safety margins. After that, the pacemaker normally goes to the magnet rate, which is 85 for a beginning of life and 65 for a ERI indicator. The magnet the pacemaker went to an 85 beats per minute, all right, but the QRS morphology changed. It became from such wide QRS complexes, from which are a RV apical pacing morphology, to sleek, narrow QRSs. Now, how is that possible? Because the patient has an RV apical lead and not a conduction system pacing lead. That was perplexing. So, in short, what did the magnet do so as to make this ugly-looking QRS to such a nice-looking narrow QRS? We took a deeper look into the ECG, and we saw that there was no visible pacing spikes that can happen on a surface ECG. So we took a screenshot of our ECG console, which better brings out the pacing spikes. What we can see here, that on repeated magnet application, first point to be noted is on repeated magnet application, this phenomena was reproducible. So it was not a one-time event. Another thing is, what we can see here is on magnet application, first there is an A pace, V pace at 100 beats per minute. We just saw the threshold margin test. Both were capturing, but starting from the third beat, there is only one spike before the QRS, the narrow QRS, and that is probably the atrial pacing spike if we see the rate, which is at 100 beats per minute for first 3 beats, and then continues at 85 beats per minute. Don't go by the size of the boxes here, because this picture is taken from an ECG console and not on a surface 12 lead QRS, surface 12 lead ECG at 25 millimeter per second. What we see here is a narrow QRS rhythm starts, induced by the magnet. Now, how is it possible? There are several proposed mechanisms which came to our mind. It could be a triggered activity, which was induced by the magnet application. Another interesting hypothesis which came to mind is that this magnet application could be analogous to a S1, S2 stimulation in the EP lab, which we do, a programmed extra stimulus. So the S1 can be as same as the lower rate which is going on at 70 beats per minute. On magnet application, the subsequent beat came faster, so it can be compared to an S2 and then a narrow QRS rhythm going on, and that it can be likened to an AVNRT sort of phenomena, a re-entry phenomena. But this rate was just 85. This rate was just 85 and not tachycardia rate of around say 150 or 160. Another important thing is that this could not be a pacemaker mediated tachycardia, because the sensing function is obviously on because of a magnet application. So what are the possible mechanisms which we can think of? We were totally perplexed. So we thought of seeing what the device saw on magnet application. So before that, we took a look at the intrinsic rhythm. We have an intrinsic rhythm which is CHB with the junctional escape. The P waves are not visible. But do the complexes appear familiar? When we compare it with the magnet response, these complexes are actually exactly the same as the intrinsic rhythm. Now, how is that possible? Again, we put the magnet again, and this time we saw from the device point of view what the device saw. So what we see here is the device EGMs. The topmost is the leadless ECG. The second channel shows the atrial EGM, and the third channel is the ventricular EGM. The DOO mode, 85 beats per minute, signifies the magnet application here. The first 3 beats are at 100 beats per minute, AP, VP going on, there is no sensing. Subsequently, there is narrowing of the QRS, which is not corresponding to the V pacing spike. The V pacing spike actually is coming after the inscription of the narrow QRS. So in short, the first 3 beats are ventricular captured. However, starting from the 4th beat, there is a QRS which is not the result of a V pacing spike. So there can be a possibility that this QRS is the result of a conducted atrial event with a short PR, which is highly unlikely because we saw the intrinsic rhythm just now. Or it could be from an even unlikelier possibility that it could conduct down this A-paced event, which led to an atrial depolarization, actually conducted down to the next QRS, which is due to an abnormally long AV delay. But how is that possible, and how do we prove it? We can see here in this strip only, which gives us an idea. When we see the magnet application being stopped here, we still see an intrinsic ventricular event, the narrow QRS, which is not accompanied by any A pacing spike. So this could be either a re-entry beat, or this could be the result of a downward conducting stimulus from the A-paced evoked atrial depolarization. And after the magnet application is removed, the rhythm goes on at lower rate of 70 at A-paced, B-paced rhythm. So how do we prove that the PR is actually equal to the RR? Such long RR. PR is actually equal to the RR. How do we prove it? So we paced the atria at different rates and checked whether the QRS rate, the RR rate, was driven by the atrial pacing rate. Only then it would prove that the ventricular stimulus, the ventricular complexes, the narrow QRS complexes were actually the result of a atrial depolarization which is being conducted antegradially. And that's what we found. At rate of 40, it was conducting 1:1 at an AV with a PR interval AV delay of around 450 milliseconds, which is too long. At 50, the PR interval even prolonged even more to around 600 milliseconds. At 60, it was 750 milliseconds. At 70 beats per minute, it was a staggering 750 to 800 milliseconds with 1:1 conduction, which gave an impression that this one might look at this leadless ECG and may say this is a VPC which is conducted VPC, and this A pace is being because of an undersensing event. But this A pace is actually conducting to the next ventricular sensed event, which is because of an abnormally long PR interval. As we paced at increasingly faster rates, we saw 1:1 conduction at 80 beats per minute and at 90 beats per minute. But at 100 beats per minute, the pacemaker on pacing at 100 beats per minute, the patient's intrinsic conduction system started vancomycin. At even higher rates, at 110, it was continuing to be vancomycin. And when we paced at 120 beats per minute, it resulted in a 2:1 conduction. So this was the patient's conduction system which had a 2:1 rate of around 120. Now this looks familiar in that normally a pacemaker behaves like what the patient's own conduction system is behaving. Normally a pacemaker, if you put the patient's if we have a patient's intrinsic atrial rate at say 120, 130, which is usually the maximum tracking rate which we put, there is 1:1 conduction till say 120, 130. After that, the pacemaker goes into a vancomycin window till the TARP rate or the 2:1 rate. And after the TARP rate, which is around 150 to 160, there is 2:1 conduction. But here it is exactly the opposite. It is as if the pacemaker is the patient. Pacemaker is the patient which provides the intrinsic stimulus from the atria, and the patient's own conduction system, the AV node, is behaving like a pacemaker. In that there is 1:1 conduction till 100 beats per minute, and from 100 to 120 there is a vancomycin, and from 120 onwards there is 2:1 conduction. So now I ask the question: have you seen the longest possible AV delay? Yes, this is the longest possible AV delay. But a question remains. When we see the first ECG, go back to our first 12 lead ECG, we can still see there were some PVCs which we thought were coming after every 4 beats due to a pentageminal rhythm. But that was at 70 beats per minute. How come? And there was a 1:1 conduction. So how come there is a narrow QRS which is coming here? Why didn't the narrow QRS come here? Because there is a ventricular paced also which is coming. This is an A paced, this is in DDD mode, and that was in AI mode. What more is seen is that even at 70, we can hypothesize that there was a vancomycin phenomena which is occurring. So if every atrial event would go down to the ventricle, but would find it refractory because the ventricular pacing stimulus would lead to a ventricular depolarization. And that ventricular depolarization would have conducted retrogradely to make the AV node somewhat refractory, leading to a vancomycin phenomena. And normally, what we see on an ECG for a vancomycin means group beating with some drop beats. Here, in this case, the vancomycin is manifesting as the appearance of a narrow QRS. This is exactly the opposite, in that normally we see a drop beat in a vancomycin. Now there is a QRS, extra QRS, and extra a pentagemini, which is giving an impression of a 5:4 vancomycin. How do we see this on a ladder diagram? The white star denotes an atrial pacing stimulus. The red star denotes a ventricular pacing stimulus. After an AV delay, the V pacing spike will anyway come. But what happens during that AV delay is that the intrinsic AV conduction still continues. But because this is long, this crosses the paced AV delay of the pacemaker and finds the ventricle refractory at that time. But because the ventricle is pacing every time, leading to a QRS morphology, which is also conducting somewhat retrogradely to the AV node, there is some refractoriness with each beat, which is leading to a vancomycin. You can see the slope of the conduction on subsequent beats, which is decreasing. And there would come a time when the PR interval would be so prolonged, which would extend beyond the paced QRS morphology and lead to a capture of the ventricle, leading to a narrow QRS. So this was such an interesting finding which we got. There was nothing to be done because the patient was doing fine, which didn't change any parameters, but we were astounded by this phenomenon. Thank you.
Thank you, sir, for your brilliant presentation and showing us an interesting case. Now the floor is open for the question. Sir, you can answer.
No, I would ask the panelists if they have any question.
Dr. Ronito, what was the underlying intrinsic rhythm of the patient?
So the underlying rhythm was a complete heart block with the junctional escape, but we could not see any P waves. The escape was not regular. There was also a possibility that, sir, I'll go back to the intrinsic rhythm. There could be a possibility that there is some P wave here which is connecting with a delay, PR interval, but as such, there were no clear P waves visible. Then because there was a 6 sinus associated also, and that's why there were not many QRS complexes which is being seen. So we can infer that the patient had a 6 sinus too, because he was atrial pacing all the time.
Anindra, was the same phenomena reproducible every time happened it? Or
Yes, sir. Yes, sir. Yes, sir. This was the
thing is that Anindra, my question is that the intrinsic rate, the RR interval not equal.
Sir, on increasing the
intrinsic RR interval is not equal.
Yes.
If you increase the atrial pacing rate, sir, in AI mode,
the intrinsic rate.
RR interval, sir, this RR is not regular.
Not regular. So it is very unlikely to be complete AV block.
A complete AV block
is
so,
not
but
a possibility.
What we don't know, sir, is there a P wave here?
But we don't know, and the QRS are narrows.
The QRS are narrow, and it is exactly the same as the magnet response.
So
yes, sir.
The pacemaker indication diagnosis was
the pacemaker indication initially, sir, it was intermittent post-operative CHB.
Okay.
Interesting case. I think it's a good ECG to think about and provoke some thoughts. But the patient is not in complete heart block because it's proven by the fact that when you pace AAI, there is conduction.
Yes.
So that rhythm probably is that either a Wenckebach behavior giving that pattern of irregular RR, because that's a definite pattern. So there is some conduction. Yes. My curiosity is, how did the first beat happen? So your explanation was PR was gradually prolonging, but if there is retrograde penetration of the paced beat,
yes,
then it should block the conduction system.
Yes, sir.
You cannot.
Yes.
You cannot jump over it.
Yes. So maybe some infraesian refractoriness which is brought about by the ventricular pace depolarization, sir, because it is not affecting the node.
I mean, two possibilities. One, that you had retrograde Wenckebach, and that when the retrograde presentation did not happen, that's when it can. Other is maybe there is a possibility that there is dual pathway in the AV in the conduction, so that one is blocked, the other conducted.
Yes,
so nevertheless,
this was refuted by the atrial pacing, sir. We did only atrial pacing, and it was driving. So this was ruled out. Whenever we paced, the QRS was being driven by the RR rate was driven by the atrial pacing rate, sir.
Yes, absolutely. I mean, so there is it's not in complete heart block anymore. It's probably intermittent AV block. Thank you.